I do want to say a couple of words about Regina. So most of you are probably aware that we lost a huge part of our trauma family, not only in Augusta or the state, but nationally. Liz let me know that Regina and um, Dennis were really the core of the Georgia Trauma Commission from the start. And anybody that's familiar with the work the commission does knows how important Regina has been to that work, most recently as a chair of the budget subcommittee. But most of all, I think we just kind of miss her smile and her passion. She was a great example for all of us. So I just wanted to kind of acknowledge that. And if we could just have a moment of silence for that. Okay, thank you very much. So I'm going to shake up the agenda just a little bit. We are happy to have and are very appreciative to have one of our local ophthalmologists in the Gainesville area, who's the current president of the Georgia Society of Ophthalmology, Dr. Zach Bellis. Just in the way of introduction, he, as I mentioned, is one of our local ophthalmologists here for us in the Northeast Georgia area. He's a Georgia guy from way back. He got his medical degree from MCG through the University of Georgia Partnership. He did his residency training in Emory. He's currently with North Georgia Eye Associates, serving the entirety of Northeast Georgia corridor, Gainesville, Toccoa, Clayton, and as well as Western North Carolina as well. So just in the way of introduction of what I'd asked him to present for us today, but like almost all of you guys in the room, we've struggled with continuous ophthalmology coverage, and that's been a topic that we've discussed in this meeting many times. In the interest of trying to forward that discussion and actually include our ophthalmology experts in helping solve the problem, I'd asked Zach to give a presentation to our as a grand rounds presentation at our facility about help us understand what we really need them for. I think one of the challenges of having a subspecialty like ophthalmology be available all the time is we don't need them all the time, but also don't want to need them all the time. So we really want to educate ourselves a little bit more about when we actually did need them, out of respect for their willingness to help. So he gave that presentation a couple months ago. It was really good. And I mentioned to Dr. Bolger, selfishly, I wanted to give it again because I want to hear it again. For one, I think I could probably hear it several times. But I also asked him to give it to our group here because I think it's very helpful. So that being said, Dr. Bellis, are you on with us?
I'm here. Can you hear me?
Yes, sir. Absolutely.
All right. I'm going to see if I can share my screen here. Let's see. All right. Are you guys able to see that?
Yes. Yeah.
Yes.
There we go. Yes, that's maximized there. All set.
All right. We're good there? Okay. All right. Well, yeah, thanks for the introduction, Matt. And I'll go ahead and, kind of apologize on behalf of my entire specialty for our lack of participation in trauma call. I know that's a major issue that everybody's dealing with across the country. And so, we've tried to work with our hospital system to put some systems in place to make things a little bit easier, especially when there's somebody not on call. And so Matt had asked me to come and give a talk about, how to triage some of these patients. Obviously ophthalmology is such a niche, and a lot of people just don't have very much exposure to that through medical school or residency. So learning how to just kind of have a game plan going in and a standardized method of evaluating patients so you can screen some of these and figure out who really needs the ophthalmology coverage or evaluation and potentially a transfer in that situation. The last thing you want to do is transfer somebody to another center that's really was unnecessary to begin with. So I'm going to run through, a few little cases and then just kind of general approach to these. And feel free to stop me at any point if you have any questions. Obviously here to help you guys out and answer any questions that I can. So first thing here, is I'm just kind of jumping into a case because this is one of the things, and a lot of this is possibly more presenting in the emergency department, maybe before the trauma service gets involved. But I'm kind of covering most ocular emergencies here. So chemical burns, I wanted to just jump straight into this because this is the one thing that we need to jump on immediately and should have been done before they even got to the emergency room, just because time is of the essence with this, and these can be such long-term issues for patients. And so the key to these is just irrigation as soon as you possibly can. Somebody comes in or they call in and they have some kind of chemical injury to the eye. You find the closest tap water if that's all that's available, rinse station, IV bag of fluid, whatever you can get, and just irrigate the eye as much as possible. And there's different ways to do this. There's rinse bottles. We have Morgan lenses that you can hook up to an IV bag. But again, worst case scenario, if you don't have something else, tap water is better than nothing. So the key is to just copious irrigation. Usually in the ER, you're running through at least a liter or two of fluid. And then the other important thing is to, once you're done irrigating, you want to really pull the lids back and inspect down in the fornices in the pocket between the actual globe itself and the inside of the eyelid to make sure that there's not any sort of particulate that's formed or foreign bodies that are down in there that continue to leach the chemical out, because those things can hide pretty easily. So it's important to really try to avert the lids to be able to do a good inspection. It is reasonable to use pH strips to check to make sure you're getting back towards a normal pH. The teaching is always to just rinse with and irrigate with normal fluid, just balanced fluid. You don't want to try to neutralize a base with an acid or an acid with a base. You just want to do something, lactated ringers, normal saline, just something that's very neutral. And these are something that, if somebody's got a significant chemical burn, they need immediate ophthalmology follow-up. These patients, can sometimes have high pressures. They can have intense inflammation that need to really intense topical steroid therapy, sometimes oral steroid therapy. You've got to really watch these patients for bacterial superinfections. So these are something that, if it's a true chemical injury and has any severity to it, they really need ophthalmology coverage. Thankfully, a lot of these, the patients have been able to close their eyes in only a limited exposure. So if you've got a small corneal abrasion that's occurred and the eye's just a little bit red and irritated, but overall, mild exposure, sometimes we can handle those things just by phone triage or something like that. But this is something you just got to really be careful with. Let's see. Okay, and this is just a couple of pictures. So on the left side, I hope you can see my mouse. So you can see that there's just really boggy chemosis of the conjunctiva there. The chemosis just means there's lots of swelling and fluid and edema of the conjunctiva. The light reflex here is really hazy and poorly defined. So that's a sign that there's something going on with the cornea right there as well. So there's probably a big abrasion there, just some very irregular epithelium due to the chemical injury. And this over here on this side on the right is more chronic findings where, if this was not treated appropriately, or even sometimes even if it is treated appropriately, you can get all this neovascularization and opacification of your cornea. And so obviously the vision is not going to be very good out of that eye. And unfortunately, we do have the ability to do corneal transplants, which is a pretty successful surgery. But once you've had an injury like this, where these blood vessels are growing in across that border between the cornea and the sclera, the likelihood of a failure of that graft is really high. So these eyes end up just not really having a great long-term potential. All right, so now to kind of take a step back, how do we evaluate these patients that come in that have some sort of, ocular involvement with their trauma or ocular emergency? And we call these ophthalmology vital signs. These are the 5 things that I expect when somebody calls me from the emergency room or somewhere to at least have a gross estimate of these things. And I understand, you're doing things at the bedside a lot of times, and you don't have the equipment that we do, and it doesn't always have to be anything too formal, but at least kind of grossly assessing these 5 things are really important for us to know and allow us to triage these patients without actually having to lay eyes on them with ourselves. So we're going to walk through each of those. So visual acuity, thankfully these days it's really easy. You can get an app on your smartphone and check this. But even that is not really necessary. We all have name badges now. There are patients in a hospital room and there's a chart on the wall. We just need a gross estimate. And the patient can kind of tell you as well, is their vision at baseline? Is it normal? Is it, really terrible compared to what it typically is? But the thing that you got to be careful on is if you do have a phone app or a near card that you're holding up, if the patient's over, typically mid 40s, and especially once they hit 50 or older, unless they're just naturally nearsighted and need glasses for the distance, they're going to need some sort of glasses for up close. And that may just be some cheaters that they get over the counter, or they may have prescription glasses for that. And a lot of times, patient doesn't come in an emergency with their glasses on. So that's just one thing to kind of keep in mind, because they may not be able to see much up close at all, and that just may be completely normal for them. We want to check each eye individually. And so we will, you can obviously have 20/20 vision and one eye can't see anything. So you want to make sure you're checking one eye at a time. People really like to cheat, so you got to make sure they're really covering up the eye that you're not testing. And for us, what I really care about when I say with versus without correction, we're talking about glasses or contacts, is I care what their vision is with their glasses. I want to know what their best potential is. If somebody's walking around and they can barely see the big E, but that's normal for them, that's not useful information for me. But if they can normally see 20/20 and now they can't see the big E even with their glasses, that's a problem. And then, if it gets to the point where they can't see anything on a formal visual acuity chart, we can take gross estimates from there. So if you stand back, can they see how many fingers you're holding up? You can do that up to their face, and you can document that. Well, they can see my fingers from 5 feet away. And that gives us a little bit of information. If they can't count your fingers, can they see your hand? Is it moving left and right, or is it moving up and down? And then if they're not even able to see that, kind of the last little bit of vision that's potential in that spot is if they're able to see light or not. So, take something with a really bright light on it, your flashlight on your phone, or if you've got an ophthalmoscope or something like that. And I kind of tell the patient, I'm going to show you this light, it's on, and now I'm taking it away, it's off, and show them what the difference is and ask them if they can, tell the difference between that. And again, if you don't have a chart available, just get the best estimate that you can. They can read my badge, or they can read the newspaper that's sitting on the counter here, or something like that. Pupils is honestly, I think, really overlooked and really an important part of when I go in to see somebody. This is a key piece that I'm really looking at because especially in trauma patients, there's obvious ocular trauma that can be involved, but there are other issues that can go on, and the eye can look completely normal, and you can have some really devastating issues going on. So the pupils can tell us a lot of what's going on, and that's going to be the deciding factor sometimes between, me sending a patient to the emergency room or somebody that's already there and me getting an MRI on them, or, saying this is something that we just need to dig out a little bit more in clinic. And so the things that we're watching for with pupils are, one, to making sure that they're round. If your pupils aren't round, we need a kind of an explanation for that, and that can be prior eye surgery, prior trauma, or later we'll see very suspicious for something like an open globe in the setting of trauma. The other thing we're looking for are the pupils equal in size. So anisocoria can be a big indicator of something major going on, especially after trauma. You've got cranial nerve palsies that can result in that, Werner syndrome, third nerve palsies, and other issues. So I want to know if the pupils are equal. And then really the big thing that I think a lot of people don't truly understand is the relative afferent pupillary defect. And, we all learn about this in med school, but it's one of those, one little section on probably one slide that you saw one time in, your second year of medical school or something. But a relative afferent pupillary defect is a really, really important sign. So a patient can come in with substantial vision loss in one eye and not have an RAPD if it's more of a focusing issue or an opacity like a cataract or a vitreous hemorrhage, all of these things. But if a patient has an RAPD, and we're going to go over what that looks like in a second, that is an indication that there is something significant going on with typically the optic nerve. That's going to be the area of focus, which may not have any findings on exam. So if you have somebody with multiple sclerosis and they have optic neuritis, they can have an optic neuritis and their eye exam and optic nerve look 100% normal. And this RAPD is going to be the one reason that I'm going to get an MRI on them. And so other issues, with trauma, with you can have an open globe can result in an abnormal, afferent pupillary defect. But this is typically something optic nerve related or something major going on with the retina. So, they've got a central retinal artery occlusion. You have to take out a humongous chunk of the retina to get an RAPD as well. So, that's a really important sign. So a couple of slides here that I like to show, and usually this is in person, a little bit more interactive. So I like to show this picture and ask the audience, which pupil is the abnormal one here? And 99% of the time, somebody's going to say, well, the right one is. And for whatever reason, people think the bigger pupil is abnormal. But the truth is you don't know until you look for other signs and when you actually test it. So there's a sophisticated way that we measure pupils in clinic where we turn all the lights out, we get the lights as dim as possible, and we measure how big the pupil is. And then you do the same thing, but with all the lights on and a bright light shining at the eye. And the difference, the amount of anisocoria between the two eyes, if it's greater in light or if it's greater in dark, tells you whether it's the sympathetic system or the parasympathetic system that's affected. And that's how you tell which pupil is the abnormal one. You can't tell by just looking. But in this, and in the way we do clinically as well, is look for other clues. So if you look, this eye has a little bit of ptosis. So this is actually a Horner syndrome. So the abnormal pupil is this one on the left, the small pupil, and they have the little bit of ptosis on that side. And then this one's a little bit more obvious because you've got a thumb holding up that eyelid there. But if you look there, you've got a dilated pupil, you've got an eye that's deviated to the side, and they obviously had ptosis that had to be raised to get a picture. So this is a third nerve palsy, and the abnormal pupil is a bigger one. So again, you're looking for other clues. Anisocoria alone is not typically something that you'd worry about some sort of Horner's or third nerve palsy. There's going to be some other finding with either of those, and those are the big things that we worry about with anisocoria. And this is a little diagram here that shows normal pupillary function and what we expect, and then an afferent pupillary defect. So when I check pupils, the first thing you want to do is try to get the lights down. I did my ophthalmology residency at Emory, so we did a lot of trauma call at Grady, and the first thing we do is we go in there and this patient's laying in the trauma bay, lights on, everything, and everybody freaks out when you go in there and you turn the lights out. But you got to get the lights down. If you can't really trust any pupillary exam or response whenever the lights are up. So first thing I'd say is make sure that you've got the room as dim as you can get it. And again, first thing I'm doing is glancing to make sure that the pupils are equal and that they're round. And you want to really look for the direct response in the eye that you're shining the light in. And at the same time, you're looking for the consensual response in the contralateral pupil. And so I check those individually. I check the right eye, make sure both pupils react normally. And then I check the left eye and I make sure that they react normally. And then you want to do what's called the swinging flashlight test. So you're going to go from one eye and quickly as you can, you're going to swing to the other eye. And what you should see is there is just a little bit of dilation depending on how fast you go, and immediate constriction back to what was equal on the other side. And you can go back and forth and test this. But if you see on this right side of the chart, this patient has something abnormal with the patient's left eye. When you swing from the right eye over to the left, you can see that pupillary response in both eyes is nowhere near as much as when you shine in the normal eye. So when you're doing this in person, it looks like the left pupil is actually dilating when you swing the light over to it. And obviously this is not an all or nothing phenomenon. You can have these that are extremely obvious, and you can have them that are extremely subtle and hard to tell. And so I do have, let's see if I can get this to pull up. Yeah. All right. So here is a website that I found that kind of demonstrates this. So again, normal response is both eyes coming down pretty equally. You can see they come up when the light's off between the two eyes, but immediately comes right back down. And then here is a severe pupillary defect. So when I swing from the right eye to the left, you can see that there's just no constriction on that side. So it appears that the eye is dilating. And this is one I think that's a little bit more mild, but shows the same thing. So again, you're looking for that slight dilation in the eye that's affected. Okay. Does anybody have any questions about anything so far? I know the pupils is sometimes a little bit where we get hung up sometimes. Okay. All right, we'll move on to pressure. So in our clinics, we use the same screening devices that are available to the operating or the emergency rooms and hospitals now. Our gold standard is called Goldman tonometry, which is a device that actually is hooked to the slit lamp. You need this special fluorescein dye that you put in. It requires, some skill and training and patient cooperation, and this is just not available in the hospital typically. So what's most common in the hospital setting is a Tonopin and some newer technology, which I think we're actually ordering some of these currently at our hospital up in Gainesville, is called an eye care. But these devices are handheld. With the Tonopin, you do need to anesthetize the eye, and they need to be calibrated, and that's always an issue. But there's really quick YouTube videos if you ever get in a situation where you need it to be calibrated and it's not working. But essentially, you're just gently tapping at a perpendicular angle to the cornea a few times to get a measurement on those. The eye care is extremely easy. You do not need any numbing drops for that one. There is a little metal probe that's magnetized that is put right here in this section, and it has a plastic ball, a tiny ball on the end of it, and you've got a button that you push, and each time you push the button it sends that probe out and it taps the cornea and it will give you a measurement. And it's actually very accurate in the kind of normal pressure range. The one thing that I see is that it does tend to read higher in clinics sometimes than what's a true pressure, but I think for our purposes, I'm not really worried if somebody's got a pressure of 30 and it's really 20. That's not a big deal in an acute setting, but it's going to give you an idea if your pressures are super high. But again, the nice thing about that is it is very easy to use, and it's really easy for the patient. They don't need any numbing drops. So once you do not check a pressure, if you have any suspicion whatsoever that there's an open globe, the best thing is to just not touch it. Don't pull the lids on it and push. The worst thing you do is kind of push on the eye and push some of the intraocular contents out. So we typically recommend some sort of shield over that eye and just minimal contact with it after you have developed that suspicion for whatever reason. Again, you need to make sure the device is calibrated, and that's pretty common. Just about every time one of these things gets pulled out because they sit so long, they need to be calibrated. But that's a 10-second process. And the other thing that you got to be really careful about is, patients want to squeeze or they have a lot of lid edema, and so you're kind of prying these eyes open, which is okay, but you just got to make sure that you're not pushing any pressure on the globe itself, or you're going to elevate the pressure. So if you're having to pry the eye open, make sure that all the pressure that you're putting is actually on the orbital rim, and that you're not pushing any indirect pressure on the actual globe itself, because you can get some really significantly inaccurate pressures by doing that. Normal intraocular pressure, we say from 10 to 22 is normal. I get called a lot about patients that pressures are, their pressure's 28 or it's 30. Even in an acute phase, if somebody's pressure goes up that high, the patient's going to be asymptomatic, and that is not an emergency. What we're looking at are pressures that rapidly rise to upper 30s, usually minimum in the low 40s, 50s, 60s. Somebody's in acute angle closure, or there's a retrobulbar hemorrhage and you're worried about an orbital compartment syndrome. So really, until somebody gets in the upper 30s, I'm not excited about it. And then, a backup for things if for some reason your Tonopin's down or not working or you can't find it is you can always palpate. And you've got your own eyes to compare to, and you've got, and you've got the patient's other eye to compare to. So the way that I like to describe this is if you take both index fingers and put them about a half an inch apart right on the outer quadrants of the upper side of the eye, and you do this through the eyelid, you just kind of palpate back and forth, and you can test this on yourself. And you can feel, and it feels about like a grape. There's some firmness to it, but if you get somebody that's in there and their pressure's 40, 50, 60, that thing's going to start to feel a lot more like a marble. So there's ways to kind of gauge this if you just don't have this technology available to you. The other part of things that we're looking for, which is probably the lowest on this list of 5 things for me, is our visual field. So the key to this is, getting on the patient's level. You want to be eye to eye. You want to do one eye at a time. And the way that to kind of test this is to compare their field to yours. So if I'm testing the patient's right eye, I'm going to cover my right eye and I'm going to check my left visual field at the same time that I'm checking their eye. And so essentially you can have them count fingers, or you can ask them if they can see your fingers moving in each quadrant, and kind of get an idea. And, we all have nightmares when we see this picture over here from, old step one test and that kind of thing, of these clinical findings based off where the lesion is on which part of the visual field is going to be affected. So it is useful. But again, out of the things that we're talking about here, is probably the least useful for me in this specific setting. And then extraocular motility. So I like to show this slide to show that the anatomy of the orbit is not straightforward in the frontal plane. So there is this angle to the external lateral side of the head. And so why that is important is because if you have a patient looking straight ahead at you and you have them looking up and down, straight up and down, you're actually testing multiple cranial nerves and multiple muscles at the same time. And so the whole purpose of checking the motility is to try to isolate which cranial nerve or which specific extraocular muscle is affected. And so by having the patient deviate, and I'll show you a slide in just a second to show this, and align their eye and their gaze of view with the orbit, that will isolate just the superior and inferior rectus muscles and the oblique muscles, so that you're only testing one vertical muscle at a time instead of a multiple, and that allows you to isolate where the problem is. So if you can imagine, the patient is looking back at us, and over here is the right eye. When you have them look to their right, that would align the eye so that the superior rectus is acting when they look up and inferior rectus is looking down. And at the same time, when their left eye is in that same gaze to the right side, the inferior oblique is making the eye go up on that side, and the superior oblique is testing. So instead of a pattern where you go up, down, left, and right, what I like to do is have the patient go into right gaze, then go up and down, and then go to left gaze and go up and down. So that way you're isolating each of the muscles and nerves to test that. Just some basic anatomy. So, I'm amazed sometimes when people call me and don't know really any sort of basic anatomy with the eye. And they're describing blood inside of the eye when they really mean that it's subconjunctival. So, a lot of times, thankfully these days, we have cell phones and people can take a picture and load it in the chart or send it to me, and I can take a look and get an idea there. But sometimes it's just not possible, and having just some basic anatomy and being able to describe what's going on can make a major difference in how we decide to triage something. So the keys are, your cornea is this front clear window in the eye, and ideally you don't see that. You just look straight through it. The area between the back of the cornea and in front of the lens is called the anterior chamber. This is filled with the aqueous humor, which should be clear as well. You have your iris, which is the colored part of the eye, and the central opening in the iris is the pupil. When you go further back on the white part of the eye that we see is the sclera, and there's a thin membrane that has some blood vessels that you can usually see called the conjunctiva that overlies that. You've got your lens in the center of the eye, which eventually develops into a cataract in everybody. Behind that is this big glob of jelly, clear jelly called the vitreous. And then you've got your retina and your optic nerve. So here is an external view. So again, you got your lids, sclera is the white part, conjunctiva is the clear membrane overlying that. You're looking straight through the cornea and seeing the iris, and there's your pupil. So again, being able to tell me, well, there's blood over where this, where the sclera is way different than somebody telling me, well, there's blood in the anterior chamber. I can see blood layering in the anterior chamber. These are very, very different things and very important distinctions. So we're going to go through a few cases now. So this is a kid, obviously, who has some periorbital edema. Their eyes are a little bit, or the lids are edematous and erythematous. But if you look at the eye, it looks pretty quiet. That conjunctiva looks pretty white and not too inflamed. So this is a lot more suspicious for a preseptal cellulitis. So patients typically have tenderness, redness, warmth. These can be mild swelling, or they can be really, really severely swollen eyelids. But the key here is that it is extremely important to distinguish between preseptal cellulitis and orbital cellulitis, because they're treated and the outcomes can be very different. So this is a little diagram that shows the difference here. So what you're worried about with orbital cellulitis is that there is involvement behind the septum. So there's a septum that goes from the orbital rim down to the tarsal plate in the eyelid. And that kind of separates your anterior surfaces in your eyelid from back the tissues that go back and surround the globe itself. And the problem is that there is very limited potential space and low tolerance for pressure in the eye socket and orbit. So when you start having all this edema back here, you get congestion and you get pressure on your optic nerve and the globe, and this can cause some permanent vision issues. So you're trying to distinguish and make sure that you don't have any what we call orbital signs whenever you see somebody with this sort of lid edema and erythema. So typically patients with preseptal or periorbital cellulitis, there's no pain with eye movement, their vision's normal, the eyeball itself looks okay, it's all isolated to the eyelid. When you start getting orbital cellulitis, patients have pain when they move their eye. They can have double vision, blurry vision, or they can start having proptosis, which is the bulging of the eye. There are other issues that are more likely to happen with the orbital cellulitis, so if patients got a fever, spiked white count, those kinds of things, they're a little bit more suspicious, but those are not as specific. So again, no proptosis, no RAPD, no restriction or pain with extraocular movements, and no decreased vision, and the eye is usually pretty white. Now you can see the difference with this patient. The lids look pretty similar. I mean, there's a lot of edema here and a lot of erythema, but if you look at that eye, you can see there's chemosis, that conjunctiva is injected, and obviously in this lower slide here, that patient's motility is not normal. That eye's not going up nearly as much as the other side. So this is a picture of orbital cellulitis. So again, things that you're looking for: proptosis, pain with movements, decreased vision, conjunctival injection, fever, leukocytosis. But a very important finding is this relative afferent pupillary defect. So this is another case where checking these pupils is really important. If you see an RAPD that's developing in somebody with orbital cellulitis, this is bad. This means that it's going south and there's too much pressure on that optic nerve, and this could result in some permanent vision loss. So, orbital cellulitis, these patients get admitted to the hospital. They're getting IV antibiotics. They're watched really closely because these can really go south in a hurry. And so this is just a CT scan showing some post-septal involvement. There's probably a subperiosteal abscess in that area, and that can be an indication for surgical treatment in these and getting ENT involved. So they get hospitalized, really broad spectrum IV antibiotics. They need an ophthalmology consult, blood cultures, ENT if there's sinus issues, neurosurgery if there can be some meningitis. Obviously, we're in close proximity. These thin walls of the orbit separate this infection from the cranial vault. So again, these are watched really closely. You're watching vision, their motility, watching their pupils, and the degree of proptosis really closely. All right, we're going to switch gears here. So these are pictures of corneal abrasions. So these are really obvious, obviously, in this picture. Sometimes on our clinical exams, it's not so much. There's no dye here, and you can see this huge abrasion, which is not typical. A lot of times, these patients are hard to examine because they're so uncomfortable. So before you examine them, I recommend giving them a drop of tetracaine or proparacaine just to make them more comfortable so you can actually get an exam done. But obviously, fluorescein on here, even without the cobalt blue light, can really highlight these areas and show you what's going on. But this patient here, you've got some really red and injected conjunctiva. There's this big area of conjunctival staining. And on this patient, the cornea is pretty opacified. So this is probably more of a corneal ulcer than just an abrasion. On this side, the cornea still looks okay and pretty clear, but you just got this big area where the epithelium's been ripped off. So patients usually present with really severe sharp pain. There's not much that hurts worse than a corneal abrasion. I mean, these things are extremely painful. They're tearing, they come in, their eyes closed, they can't open it up, blurred vision. And there's usually some sort of history of trauma. There is a condition where patients can wake up with these things. They just have this loose epithelium, and when they wake up, their lids stick a little bit and can rip a little piece off, but they usually know. That's not usually the first time that they've had that. They've usually dealt with that in the past, but usually there's some sort of history of trauma. And so this picture here shows a fluorescein strip. These are really nice to use if you don't have a drop of actual fluoresce, which is a bottle. Most of the time in the hospital setting, because it doesn't get used enough, these strips are a lot easier to use. Before you actually touch the eye, good to just put 1 or 2 drops of the proparacaine on there. have the patient pull their lid down, touch the inside of the eyelid or way down low on the conjunctiva. And like just one little quick touch will usually put enough of the dye on there that once they blink, it will spread around. You don't want to put too much dye in there because that's can make it hard to see small abrasions. And you've also got to watch out because mucus, if there's any strands of mucus in there, they will stain. So I've gotten calls a lot in the past for corneal abrasions where the cornea was actually clear. It was just some piece of mucus that was stuck on there that stained. So it's a good idea to also to kind of move the lids or have them blink a lot to confirm that that spot's not moving around. But once you get the fluorescein on the eye, we've got wood lamps usually in the ERs, which have the magnifying glass with the blue light. So those allow you to examine it. But actually, when I'm seeing patients, I carry this thing around with me and kind of my call stuff. Bought it off Amazon for like $5, but it's a little cobalt blue light. You click it, turn it on. It's really small, it fits on your keychain. But you put some fluorescein in and shine that on there, and with the naked eye, you can see an abrasion pretty easily. Treatments for these broad spectrum antibiotics for prophylaxis. If somebody wears a contact lens, they have to be on a fluoroquinolone. They're at high risk for Pseudomonas infection, and so they need to be on generic moxifloxacin is pretty much ubiquitous or available everywhere now. So that's the go-to for that. If they don't wear contact lenses, polymyxin trimethoprim is also a really good option. Pretty wide spectrum of coverage for something like this, and these are usually for just a prophylaxis 4 times a day kind of thing that we do. Antibiotic ointment, I use erythromycin. That's the most commonly used, can help with the discomfort. It's not a great antibiotic for this situation, but it does provide a lot of comfort, and they can use that 2 or 3 times a day. If you've got this raw breakdown on your cornea, every time you blink, it rubs over that. That's really painful. The ointment kind of provides at least some sort of lubrication between that, so it's more comfortable for the patient. And the important thing that I would like to point out is just avoiding topical anesthetics. So there is real potential for people to literally melt their cornea and lose their eye. And, there's nothing worse than having an option to take something and be told not to do it and have the bottle sitting there in your hand. If you're miserable from these abrasions, you're going to take that drop. And there's a lot of articles in the emergency literature now about how safe it is for corneal abrasions. And I actually agree with their point. And I do think limited supplies of that are probably safe and warranted in those situations. But I 100% disagree with the ability for the large majority of emergency providers to tell the difference between a simple abrasion, which that's okay for, and an early corneal ulcer or a more complex abrasion. That's where my issue is. So no doubt malpractice if somebody has an issue and you gave them topical anesthetics at this point. So just don't do it. So this is now switching over to a more obvious corneal ulcer. So in this patient, there is matter on the lids, mucoid discharge. Their conjunctiva is really injected is how I describe this. Their cornea is not clear. You get this really mottled light reflex and irregular. There are these little focal opacities in the cornea. If you look closely down here, that's called a hypopyon. Those are cells that are in the anterior chamber that have settled down in the bottom. So this is a pretty classic corneal ulcer that's a little bit probably later stage than what some people would present in the first day or two. This has probably been going on for a few days. But these descriptive terms really help us and kind of know what's going on. This is a much more severe ulcer. So again, a lot of injection of the conjunctiva. There's chemosis there, and you have a large infiltrate is what we would call that, and opacification of the cornea. Again, another one, injection of the conjunctiva and a focal infiltrate there. So these are most likely due to some sort of mechanical trauma with something that was contaminated, or most likely, most common cause is sleeping in your contact lenses. If they do wear contact lenses and you think they have a corneal ulcer or an abrasion, they need to discontinue their contact lens wear. Early detection of these is really important. So if you have somebody that has an abrasion, those things should heal up. Even a huge abrasion should heal up within a couple of days, 3 days, 4 days max. If something is going the wrong way with an abrasion, you've got to have a really high suspicion that there's an ulcer developing. And treatment consists of aggressive topical antimicrobials. And the problem with the ulcers is you don't always know what it is. And we treat these empirically a lot of times. They can be bacterial, viral, fungal, or parasitic. This is a very classic corneal dendrite. So you see this branching pattern with these terminal bulbs. So this is herpes simplex virus keratitis. So if you see this pattern, then they need antivirals. A lot of times we do put these patients on prophylactic antibiotics as well, just to prevent a bacterial superinfection, because this is broken down epithelium where you can allow bacteria to penetrate into that cornea. But these really need an antiviral treatment. And they can be associated with skin vesicles. You can get conjunctivitis with this. You can get inflammation in the eye with uveitis, and they can be treated with topical or oral antivirals. There's a couple of different topical treatments for this. One of them, you have to take it 9 times a day, which nobody will do, and it's very irritating to the eye. So that's kind of an older treatment that most people don't use. There is a newer treatment called Zergan, which is a gel, which is a lot better, but extremely expensive if it's not covered by insurance. So I'd say the majority of people probably treat just with oral antivirals. And then we add, artificial tears and things like that to try to help with comfort. It's very important to avoid steroids in this situation, because it can become a major issue and get a lot worse with that. And it's just a good idea for non-eye care providers to not be prescribing steroid drops to begin with, in my opinion. Corneal foreign bodies. This is a very, very common thing. These patients come in and crazy enough, as bad as a small little eyelash in your eye or a piece of grit or anything can get in your eye and how uncomfortable it can be. I'm shocked at how often a patient comes in and 3 days, 5 days, 2 weeks ago got something in their eye when they were welding or grinding or something like that, and they made it that far without coming to get to me. These don't really hurt them that bad until the inflammation sets in. So 3 days later, this happened on Tuesday, Friday afternoon, their eye starts killing them. And it's when that inflammatory reaction starts that these really become painful. And why they don't present earlier, with as bad as an abrasion hurts, I still haven't figured that one out. But the key to these is you want to make sure that they're, partial thickness and they don't go full thickness through the cornea. The cornea, if it's a small enough injury, can self-seal. So you've got to have a high suspicion that there's something didn't go full thickness and hide itself. It can go through the iris, embed in the lens. It can go in the back of the eye. So again, when you see this, you want to make sure that pupil is perfectly round. There's no blood inside of the eye. The pupil's reacting normally. They haven't had a substantial change in their vision related to, sudden cataract formation because a foreign body went in there and hit it. So here's a picture of what we call a Seidel sign. If you have a slit lamp available and you can look at a patient, you can use that fluorescein strip to kind of touch over the area of suspicion. And what you'd see is aqueous actually kind of running a path through and washing that fluorescein away. And so we call that Seidel sign. If you see that, that's an indicator that there's a full thickness injury there. That's an open globe that needs to be fixed. So again, checking them with fluorescein before and after removing to make sure that you didn't pull something out that was plugging that hole. A lot of times these foreign bodies can just be swept away. You take a cotton tipped applicator, soak it in some Preparecane, numb the patient's eye up, and you just kind of rub that area and pop it loose. A lot of the ER doctors will use needles to do this. Once you get the big foreign body out, that's the main thing initially. Put them on an antibiotic to try to prevent an infection. I do see a lot of times people come to me after they've been in the ER where they really dug around trying to get all the rust out and that kind of stuff, and it's really not necessary. So one, you're going to really muck up the stroma of the cornea and cause some issues, probably more than you're going to help, especially if you're using a sharp needle. But honestly, if you let those sit for a couple of days, that rust tends to kind of congeal and more solidify, and it comes out in like 1 or 2 big pieces. It's a lot easier to remove after a couple of days, and typically that's not a big issue for the patient as far as the discomfort once you've got the bulk of it out. Conjunctival lacerations are not that common, but we do see them a lot. The key with these is that you got to make sure that there's not some underlying injury of the sclera. Most of the conjunctival lacerations are going to do perfectly fine. They're going to heal up. You're going to make sure it's clean and there's not any foreign bodies under that area. You can get some BSS or some saline on a syringe and kind of squirt it in there and wash things out and clear it off and inspect that area. You can mobilize and move the conjunctiva around with some cotton tips. to just make sure that there's no underlying scleral injury. But if it's less than a centimeter, we don't typically repair these. They're just going to kind of close up on their own. If they're a lot bigger than that, then a lot of times we'll put a stitch or two in it. And with these, you don't really need antibiotic drops necessarily, but erythromycin ointment mostly for comfort. So high FEMA is also, extremely common in the trauma setting. So what a high FEMA is blood in the anterior chamber. So typically a blunt injury has caused some sort of damage to the angle, which the angle is the structure where your iris, your cornea, and the sclera all come together, and that's where the fluid inside of your eye drains, and it goes 360 degrees around the edge of the cornea. And there's blood vessels over there, and these blunt injuries can cause damage and rupture of those blood vessels, which fills the eye up with blood. And these can be, smaller like this one, or you can have the entire anterior chamber filled up with blood. So the issue with these is, again, you got to make sure, based off the mechanism of injury, you're not suspicious for a foreign body inside of the eye that's hiding in there, and you got to have a high suspicion for an open globe as well. It's important to check the pressure on these patients. That's one of the main things that we're watching with these, is to make sure that their pressure doesn't get too high. And a lot of times these patients have to be put on glaucoma medications. I had a patient this week that we had to take to surgery to wash the blood out because their pressure was too high and the blood wasn't clearing. And it's also important to get a sickle test on these patients, or get a history if they are at risk for sickle cell, because those patients have an entirely different treatment algorithm because of how susceptible their eyes are to ischemia with high pressures. So those patients are watched much, much more closely, a lot lower threshold for actually going to surgery to clear things out if their pressure is running a little bit too high. These patients get a shield. They're told to be on bed rest, essentially. You can have a risk of rebleeding within the first 7 days, which can usually be a lot worse than the first one as far as long-term issues from that. So again, pressure is the key thing, and close follow-up with an ophthalmologist and making sure that they're really taking it easy. Minimizing unnecessary blood thinners if they're able. We typically put these patients on a dilating drop to prevent the iris from kind of going up and down and lowers the risk of bleeding. We put them on a steroid drop to help control inflammation. And the more that these patients can sit up and sleep propped up is helpful as well, so that blood can kind of settle out of the visual axis. And because a lot of times we have a hard time seeing the back of the eye to make sure that the back part is okay, because that blood's floating around, you just can't see through it. Orbital fractures, also extremely common. So this was a huge issue when I was a resident at Emory. Depending on who was on call for facial trauma at Grady, it was either ENT, plastics, or maxillofacial surgery, determine how often we got called on these. So there were certain specialties that would call us for every single one of these things. Didn't matter what time it was. They wanted us to see them, and then others would handle a lot of these and only call us if they were planning to go to surgery. But essentially, if you take a shot hard enough to your face and around your eye socket to break your eye socket, you should have an eye exam. The question is the timing on this. And so if the patient has no visual complaints and there's low suspicion, our general rule is about a week. Within a week, they need to have an eye exam. If there's any other suspicion of other injuries, then obviously that timeline gets moved up to potentially right now. This patient over here is what we call a wide-eyed blowout fracture. That means that the eyeball itself looks really good, but you've got some entrapment. You can see this clinically by the eye not being able to go up whenever they're looking up. And radiographically, you see these little small fractures where, something herniated through the fracture, but the fracture closed back down once that pressure was relieved from the impact, and it traps some sort of soft tissue, whether it's a muscle or just other soft tissue there. These are actually an indication for emergent repair. So if you see something with some entrapment like that, that needs to be fixed really quickly, especially in kids, because those muscles can fibrose and leave them with permanent motility issues. Larger fractures like these are in the urgent setting a lot less worrisome for me. So a couple of things. One, you're not going to get any entrapment from something like that. And two, this provides a pressure outlet. So, it's really common to see retrobulbar hemorrhages in the setting of orbital fractures, and it basically decompresses the orbit, so all of that blood has a place to go, so that you don't build up an orbital compartment syndrome. Now, in the long run, that still may need to be fixed because this eye may start sinking down one day, but in the acute setting, that's not as big of an issue. So things with orbital fractures, you want to assess for double vision or motility restriction, and really looking to make sure that there's not any entrapment, because those we like to fix sooner. Big thing is oculocardiac reflex. So this kid that's got this entrapment here, you ask them to look up, there's a really good chance that they're going to get bradycardic, or they'll start feeling nauseous when they're looking up, and that's an emergency. Those need to be fixed right away because that's potentially life-threatening. You obviously need to rule out an open globe, so doing a good examination of the anterior segment. And again, an ophthalmic exam within a few days. And here's the indications for repair. So immediate, if there's entrapment, there's oculocardiac reflex, or this wide-eye blowout fracture, which I was mentioning. And delayed, we fix these if they have persistent double vision, more than half of the orbital floor, if there's some other complex trauma going on. This patient has a retrobulbar hemorrhage, so they've obviously got a big subconjunctival hemorrhage as well. But on the radiograph, you can see all of this back here behind the eye. There's proptosis, that eye is bulging out. So a retrobulbar hemorrhage alone is not that big of a deal. What you've got to make sure is that they do not have an orbital compartment syndrome. So what you're looking for in these, obviously pain is not very specific, but decreased vision, if they have proptosis, you can push on the eye if you're sure that there's not an open globe and kind of check to see how hard it is to push back. Honestly, that's not very useful in your setting. But what we're looking for here, elevated pressures, what I call tense lid edema in the presence of an RAPD. This is a big deal. This needs to be, relieved immediately, because within 90 minutes, these patients can have permanent vision loss and blindness. And when I say tense lid edema, people can have really swollen lids, but you can kind of pry it open. But if you see somebody that has proptosis so much that you can't separate the inside of the eyelid and get any sort of gap from it in the actual surface of the globe, that's what we call tense lid edema. So essentially what's happening is the pressure from posterior in the retrobulbar space is pushing the globe forward, and it's stretching the tendons in your eyelid so much that there's no room to give. And that's where the pressure in the orbit builds up and causes this. So again, really, really important finding. If you see an RAPD in this situation, that patient needs their lids cut immediately. And this is something that, I would want the ER doctor cutting these things before they even call me if they see this going on. And so if you're not familiar, you have a lateral canthal tendon, so your eyelids come down and you've got this tendon that comes from the lateral side of the eyelid and inserts on the orbital rim. So essentially what you do is you make a lateral incision just straight where the corner of the eyelid is. You cut out, and then you grab the lower lid with some forceps and you pull it out as much as you can, and you take the tips of the scissors and you kind of strum back and forth in that area, and you'll feel the tendon, and you just cut until that tendon is completely released, and you want that eyelid literally flopped down, hanging down loose. If it's not hanging down loose, then you haven't relieved the pressure. We also treat these pressure with patients with IOP lowering drops. You don't want to delay this treatment. If you think this is what's going on, you don't want to wait for the CT scan to prove it. This is a clinical diagnosis, and they need to be treated immediately. Traumatic optic neuropathy is not something that I see that commonly, and it's definitely a diagnosis of exclusion. So if somebody comes in after trauma and they've got unexplained, loss of vision, this is something that's on the list. But again, it's just not that common. And what typically happens is some sort of injury, and that's caused a fracture in the posterior orbit that's called a direct impact to the optic nerve and caused damage. Or indirectly, these patients, a lot of times with frontal injuries, so if somebody is riding a bike and they fall and they hit their forehead, that impact can cause indirect injury to the optic nerve as another one. But they will have an RAPD as well. So again, that kind of points us in the right direction of knowing that something really serious is going on and that there's some sort of etiology that we need to look for. Let's see here. I'm going to skip through a couple of these just to get through there. A picture here. Somebody have a question?
I don't think so.
Oh, okay. So this was actually a case at our hospital. ER resident called me as an 87-year-old lady. She was confused, didn't really give a good history, had some eye surgeries before, but really just didn't know a whole lot, was reporting some blurry vision. And the resident called me and said, "Hey, this eye's like it's something, her pupil's just not round." He's like, "Can you come take a look at this?" So I come and look, and he was exactly right. He knew something was off, but he didn't know exactly what. But this pupil was irregular, and what we say is the pupil peaks to the problem, and so that pupil is pointing over towards where an open globe was. So she had a little laceration right there at the lateral edge of the cornea and the sclera. And what happens is you release this pressure inside of the eye, and the iris is going to kind of follow that pressure gradient until it plugs that area. So if you see a peaked or irregular pupil, then high suspicion for a open globe injury. You know, there are some patients that have had prior ocular surgery and their pupils don't look normal, and you got to kind of take that into consideration. But in a patient with no history of that in the setting of trauma, highly, highly suspicious that there's an open globe. So again, larger picture here. Sorry about the quality of that, but definitely a uh, big indicator there. Sometimes open globes are obvious like this. You've got iris that's just jumping out at you. This was a patient that I saw at CHOA, had been transferred from an outside hospital. They did not even know they had an open globe. I can't remember exactly why they sent them, but this was a kid who was in a classroom, and another kid threw a pencil at him, and the lead point just hit him perfectly in the cornea, just enough to puncture that, and the iris kind of pooched out there. But again, the pupil points towards the problem. Other things to make you worry about an open globe is having a severe subconjunctival hemorrhage. So if it goes 360 degrees around, and especially if it's kind of ballooned up on you and really edematous and swollen, that's highly suspicious that there's an underlying scleral laceration. If their anterior chamber looks really shallow and there's not room in there like there's supposed to be, again, irregular pupils or a high FEMA as well. Once these are suspected, we essentially tell people to stop touching the eye, put a shield on it. We do need a CT scan typically on these, and a lot of times you'll be able to see from the CT scan there's going to be a little irregularity in the area that's ruptured, or there's a vitreous hemorrhage that's showing up on there as well. But so the CT scans typically help us in cases where we're kind of borderline on going to the operating room or not. Patients get NPO, bed rest, IV antibiotics, update tetanus, and pain and nausea control. And then just to end here, I've just got a couple of pictures of some very common things so that if you see these, you'll know not to be too worried. And again, just to kind of help you with descriptions of things. So here, this patient kind of has this hypertrophic lesion on the conjunctiva. This is called a pingueculum. These are like sunspots on the eye, essentially. It's just keratinized conjunctiva, extremely common. If those progress or get bigger, they can develop into these pterygiums, which is where the conjunctiva is now stretching across onto the cornea. These again are extremely common, no problem there. This is a mild subconjunctival hemorrhage. See these things all the time. You can see that they also have some ecchymoses and bruising of the eyelids around there in the setting of trauma, but a little subconjunctival hemorrhage. This is a picture of a pretty bad cataract. So you're looking through the cornea, and you can see through the pupil there that there's this opacity. So everything else with this eye looks good, but that is a cataract there in the center. And you can tell that by that you can see the iris features clearly. So sometimes it's hard to know, well, is this problem in the cornea or is it in the lens? And if you can see the iris details really clearly, it's probably in the lens and not the cornea. All right, that is all I've got.
Thanks a lot, Zach. That's awesome. I couldn't have that. I had one of the residents ask me actually this week if we had access to that presentation. I think we do, at least in our shop. I don't know if that would be possible to have access to those slides. I made a few photos that were real long, so were some common things that we have to differentiate on. But that's really good. The question I had, you already answered, and that's the fracture question and the entrapment question. Because that's probably the most common question we got to answer for our facial surgeries. But does anybody in the audience have any questions to that?
Yeah, so y'all definitely have it. I sent it over before I did that presentation for y'all, but if I need to share it with anybody else, I'm happy to send this presentation to whoever needs it.
Yeah, I'll be happy to share it. If you can just send it to me, that'd be awesome.
Okay.
Again, thanks a lot for your time. We'll let you get to your evening. Again, we really appreciate your work and let us know if there's anything we can do to help.
All right. Thank you all. Have a great meeting. Bye.
All right. So in the interest of getting back kind of on track a little bit, we'll go back up to the top of the agenda. As we talked about before, Georgia's Committee for Trauma Excellence is a very active and mature committee. And I kind of wanted to model what we do a lot after them, but there's also a lot of overlap. So Lynn Grant is the current chair of that committee, and we've begun to kind of try as best we can to pull the road in the same direction, so to speak, and make sure that we're collaborating and as much as we possibly can, not repeating work. So in that vein, she's been kind enough to let me sit in on their last couple of meetings, and I invited her to ours, and I kind of want to put her on the spot and keep her on the agenda just for updates of things that we can help each other with. But she said, "Well, what do you want an update on?" I said, "Anything that's important. Anything that we can collaborate on." So, Lynn, I appreciate you being here and appreciate your cooperation.
There we go. Thank you for having me. Just real quick, because we did just finish our meeting, it was quite a lengthy, but just a couple things that you guys may be interested in is our pediatric subcommittee's been working on a one-page quick reference for assessment, stabilization, and transfer of a pediatric patient. They actually got that completed. It's very simple and clear, colorful, so it'll be easy to look at for our smaller centers that do not take care of pediatric patients. And we hope to have that released very soon. It's in the final stages. I know we had help. Dr. Baxter, the pediatric TMD, is working on that poster as well. And they're continuing to work on a pediatric transfer toolkit as well to send out to our small centers just so they'll know how to take care of these kids.
One quick question. I don't want to interrupt too much, but I know Liz, the commission, helped us out tremendously by kind of helping branding that and get that out for us in terms of the adult transfer toolkit. So I hope if that hadn't happened already, that's in the works as well.
We're on it. They're on it.
Always, I should have.
And then very interesting. So we always review a couple of the ACS standards in our meeting just to kind of get a group conversation going how other centers are meeting all these required standards we have to meet, and we actually picked the ophthalmology service for our meeting today, especially because it was just updated in July. So the ACS updated the grade book, and this was one of the standards. So this is applicable to level 1 and 2 centers that they must have continuous availability of ophthalmology coverage that they added, or must have a contingency plan to ensure optimal trauma coverage. So that's going to help a lot of our centers. I don't think that was a saving grace. A lot of people have transfer agreement from place with other centers that have the 365 24/7 coverage. Some centers said they are looking at some tele-ophthalmology also to meet that. So I think that's going to be very helpful. Anything else?
No, that's great. I was I'm gonna put Matt on the spot too, because he helped us a lot with kind of moving the ball for us on ophthalmology coverage. So Matt, you want to give us an update on your guys' setup?
Well, we contracted with a group out of Atlanta to where we can do the telecoverage, and we probably use it about once or twice a month, but it really saves on having to transfer a patient out or getting a urgent evaluation. And worked out really well. Our APPs have all been trained on it, and they measure the intraocular pressures, and then they actually get on there simultaneously with the ophthalmologist and do the exam, and we clear a lot of eyes that way without having to transfer. I mean, we rarely transfer that. It's costly, but it's all we got. Again, there's another group I think I talked to you about that's looking at doing it as well, but we haven't connected with them yet. So
we actually connected with that group that you guys were considering to be forwarded to us, and, their marketing was a little bit ahead of their capabilities. I think it's safe to say, but they are, up and running. I actually got an email from the, I guess, the CEO of that company that's offering that service. And the basic model is, they have local ophthalmology techs that will actually come and do an exam and with the expert. And so they actually have someone in person that can do a little bit more than what you could do maybe with ophthalmology. And then, they'll return, which are urgent care. But like I said, it's not as mature as I thought it was, as it was marketed to be, but it's good. So I don't know the name of the company off the top of my head. That's interested. I can certainly leave that to you.
The group we currently use is, they train all our APPs in their facility, and it didn't really take much training, and I'll feel pretty comfortable with it, work out. Unfortunately, some of those APPs have moved on to other job positions, so
yeah,
I'm down two right now.
that'll happen. Yeah, stay away from mine.
Well, I don't keep having babies and taking a ambulatory setting jobs now, so.
Any other creative solutions that anybody would like to share? Well, that's gonna be an ongoing discussion, and so we'll probably keep that on the agenda for updates as services mature. What I'll just say for us, I mentioned this to the GCTE committee as well. Just having that conversation really moved the needle for us, because it allowed us to assess the current cost of the alternative, and rethink what we were offering in terms of as well. So it's kind of helped us maybe close the gap between what was required for coverage cost wise and and I attribute all that to just the conversation we had. That's what kicked it off. So please share had views like that. So any other, assuming nothing else with ophthalmology, Lynn, basically just provided the update on our early adult, transfer poster that went out. I know having a smaller hospitals than our, system, that they were received and, they've been placed in the right spots, and hopefully I just would emphasize to this group, like we talked about before, just realize that we are encouraging our smaller hospitals to transfer and make the decision to transfer early. So inherent in that is we have to say yes. Just always keep that in mind. Know what those other triggers are that we're asking them to follow. That's the update there. I wanted to do one thing with the reason I had Dr. Christie up here with me as our state COT chair. I wanted to kind of dive a little bit into, for a few minutes, the COT membership requirement, and kind of the logistics of that for our readiness cost reimbursement. That is one of the requirements. If you guys weren't aware of that, hopefully that now you are. But I was curious about the logistics of how that communication happens, and whether or not, this committee and the COT committee, since they're basically the same people, how do we best overlap, cooperate, collaborate, make sure that we're not, again, repeating resources. I would invite Dr. Christie this to kind of make a comment on those logistics.
All right, this is Ted, the closest to part. I generally, which I appreciate the membership requirement, the COT stage here. What actually happens practically is someone will tell me saying, I'm not a member, I'd like to renew or I'd like to become a member. And I will make a note of that and create doing the best I can to keep up with it, great membership law. In years past, it was be associated with, since I've been chair, I actually not asked or thought of assessing fee. So pretty straightforward. I feel like we need to be a member. Have to, we'll put it down, send you direct feedback, verifying membership. Now, on that end, I do report to the region chief, and I will grow as got a lot of new numbers and this grows and I'll report that up to the region chief and then, takes that as a central city. But that's about as, from my view, that is all. That's not common, I think it's pretty good. Is that, I mean, you disagree with that, or that's,
And so,
there's no stat, so it's pretty much.
I guess that, one of my two questions, so that let's see, this, on your iPad,
Yeah.
in your brain.
I do have them available, yeah, so it's the next question.
And, so my second question, I guess, is for Liz, I'm assuming that's just a checkbox on our applications. And it's, is it honor system? Is there a way that that's double checked?
Yeah, it's pretty much honors.
It's pretty much on our system. It would be nice, and I know you were gonna introduce Dr. Bolger a little bit later, but she, with her vast experience heading the COT,
Yes.
might have some germane comments to us as to how we could, or how other states kind of do this and track this. And just for background, it's a pay for performance metrics with your trauma center agreement. So it's assigned a certain dollar amount that you maintain your membership with COT. And the goal around it is just to make sure that there's engagement on the state COT level and involvement. And that might open there to Bolger if you wanted to. Charity, any thoughts you have? A couple.
Thanks, because I was trying to figure out what you're talking about, it being a requirement. So it's not a VRC requirement. You're talking about the Georgia Common Commission.
For the funding.
I understand. Okay. Yeah, I think, we've been working hard in COT to ensure that we have a robust regional structure. And, that's the heart and soul of the history of the COT. If you go back, it was founded by Sutter in 1922. He intentionally picked service from around the country, and they were told you had to go back and form a local committee. And over time, those evolved into state committees. And so there are actually 57 state committees. You wonder why, because there are 50 states, some states are really big. So if you're a big state like Texas, you get one committee, California. I think over time, it's going to ebb and flow how active the regional committees are. There's certain committees that have always been really active. The Chicago committee, for example, which has been its own committee for a long time. It's incredibly active in bringing all the hospitals together in Chicago. But it's been variable, I think. And so many states like Georgia have developed a parallel structure, right, with the state trauma system committees or the trauma commission, which is great. But we want to make sure that all the trauma medical directors are engaged in all that. So it's a kind of, I think it's a good criteria that you developed. You have to figure out how you want to operationalize it, right? It's easy to become a member of the state COT. You just tell the state COT chair you want to be a member. That's true everywhere. But you can also build out that infrastructure a little bit. You can have vice chairs for the state, and there's actually the number of vice chairs you have, and you have a vice chair be focused on a particular issue like pediatric readiness or arm creation or something like that, we'll talk about tomorrow. Then you give projects for young people, which is really great. And if you're a vice chair, you can come to our national meetings and see what's happening in one. So I think, I don't know much about how the Georgia COT is organized, but I think that there's opportunity to think about how you engage more and more people in the regional committees, and that feeds up into the national committee work. And there's lots of work to be done, so if people willing volunteers we can take. I hope that answers your question.
Yeah, it does, and I think I would also love to know, talking about just building out infrastructure, so it doesn't rely on one person's like email, are there like websites that people set up for state? Okay, so we probably could look at something like that, because that would be a good use of some funding for us to at least facilitate that infrastructure, so. I know the COT has some coffers and some funding coming in from ATLS courses or something, if I'm not mistaken.
Yeah, that's how it's generally supported, is a code tax from ATLS students, and that provides some funding for the state COT. And that's pretty universal around the country. But there's not a lot of infrastructure, not always a person, available to the state chair who can set up a website. So if you have infrastructure that you can kind of overlap, I think that would be great.
That's great, thank you.
Yeah, I understand. I think that's my thought in terms of maybe kicking off this discussion is how we can interact and overlap, similar to what we talked about with the GCT. They've been a mature functioning committee, and functional and productive for quite some time. I'd love for us to, well, and we are the same people. So
Talk a lot about this at the last PMD meeting too, with like, it is this group,
Right.
right? I think, and maybe you will have some insight on stage, like Michigan, you guys have robust, but we have a robust GPLIT. Are there COTs, like, I guess, how do they operationalize that? I mean, maybe if we'll see that when we go to Michigan in October, because it is, for me, it feels like, have a vice chair being a part of both, and then we are essentially
Right.
Is probably how you collaborate well in operation by something, but everybody's put the quality.
Yeah, and there's more kind of firepower on the sidelines with the COT. You guys aren't in the army in the state of interested residents, interested medical students, and this amount of project applicants. Just waiting for somebody to volunteer on national level, the COT will get for that. But honestly, we talk about collaborating, that same talent, that intellectual skill set right now, just sort of share media information. I could imagine based on one of the last meetings we had, the idea of like interstate transfer guidelines. Just some of the COT, the membership of the COT, I realize that everybody is going to have different working responsibilities, but consistent interest in them to study and research, to publish. I don't see why we couldn't work amongst ourselves with 3 different transfer, whatever our transfer patterns are, come up with something where we can use some of these very interesting minds. Me about what to do. This is an idea. We talk about the East guidelines all the time. Why can't we have Georgia guidelines?
Good discussion. I don't want to cut it short, but we are running a little bit short on time. And I wanted to use the last few minutes to introduce a concept that we'll be talking about. And one of the reasons Dr. Bolter's with us is to lead a panel discussion tomorrow during our meeting, our GPO meeting, on this concept of RMOPs, or Rural Medical Operations Command Centers, which was a concept that was relatively foreign to me up until a few months ago. But in terms of preparedness, or a little bit of background, so we can participate in that conversation tomorrow, I'd ask Dr. Christie and Dr. Bruce Benjamin to maybe give us a little bit of an intro. So I think there may be a couple of slides. So,
well, I guess I did sort of a global COT update. I had RMOC at the end. So yeah, just picking up, I'll blow through this and we'll get to Liz's portion. Next slide, please. So just as a comprehensive overview, we, the state of Georgia, do have a future trauma leader this year. Christine Cassner went through a very competitive application process. Was just awarded a position in the program. It's a 2-year term. She will be receiving professional development opportunities, curriculum specific to COT and ACS, high level training as a leader. She'll also have multiple projects, and opportunities for projects at CAT level, for everything from inception to completion, which is a huge benefit to the national CAT. So you can see, Dr. Pastor, please extend a form of congratulations. It's a wonderful thing, and those reflect nicely on the state of Georgia as well. Next slide, please. This is the CAT rolling meeting for this year as it relates to 2025. In September, the 4th to the 7th, the Gage Ashner Resident Paper Competition in Georgia CAT will be held in the Island in conjunction with GTC. And 4th to the 6th is Central CAT at the Clinical Congress in Chicago, Illinois. And in November, that's supposed to be 14th, 9th through the 15th. That's the Region Resident Paper Competition this year in Jackson, Mississippi. And in the spring 2026, CAT and I'm aware, sure of time that also. Let you know what happens. Next slide, please. In terms of programs, there's the National Pediatric Readiness Project. This is led by the Health Resources and Services Administration. This is through the Emergency Medical Service Children. Its ultimate aim is to ensure that every emergency department is prepared to care for kids, no matter where they come from. Field programs such as ER physician, pediatric emergency care coordinator, trauma teams, best practice guidelines, tools, and strategies to strengthen care delivery at all levels. And I'd say in terms of project life cycle, this is maybe not quite infinite, but it's something we'll be growing. We will be looking, usually list friends, begging for any volunteer efforts, but we'll probably be a state champion for this. So if you know somebody who may be interested, please send them my way, and or mention warn them when we call them. Next slide, please. Another program is Bridge Second Matter. This is an initiative that was sort of born out of the CAT advocacy pillar. The idea is to highlight trauma centers and challenges as well as the value of a robust trauma system to your legislators. And to be fair, thanks to the commission, Georgia is it's not a new idea, but there's a lot of stakeholders on the national scale who are putting time as well as effort into allowing toolkits, checklists, talking points, media guidance, and other efforts to sort of celebrate the good work that trauma centers do. The idea is to get your legislators into your center and show them everything that you were capable of and things you need. So this is the first rollout was supposed to cover somewhere in August. Not sure that the toolkits and all that kind of thing already. I haven't really had a report of the successful implementation of this, but this is going to hang around, and I think there's a great opportunity for all of us in the state of Georgia to use this for all our centers. Next slide, please. So this leads into the RMOC discussion, and this is to be clear, what I'm about to tell you, I have like permission to say at this point, and I'm not making anything. Everything I tell you is my own words, not the words of government and everybody else. But yeah, June 2024 executive summary of the United States Committee on Armed Forces, the National Defense Authorization Act, fiscal year 2025. You can read this yourself if you like, but it does create some pretty compelling language as it relates to conflict on a global scale. Basically, there were sort of two reports from the Defense Health Board, or Part 1 and Part 2, that surrounded concepts related to a prolonged theater of care. And this is going to lead into, next slide, please. Our concerns for readiness planning. The United States Senate Committee on Armed Forces articulated clearly that we're moving towards, or at least there's a potential of continuing towards combat operations on a multi-front scale. I was in the meeting at CAT a year ago. This is like one of those serious meetings. I'm usually trying to find a way back, but I said at the title of the meeting was, "Hey, we're the federal government, and we want your hospital bed. We need your hospital." And it was pretty compelling stuff. I sat there and listened, they learned, and the presenter spoke in this kind of, let's say, future present tense, non-committal, and I was like the guy, and I did, but I'm more aware now for a lot of different reasons, what the message they were trying to send, and I'm certainly more sensitive to that message now. So there is potential for a large scale, multi-front combat operation over the United States. And if that were to happen, models right now project, daily casualties that would have to be, mobilized out from, front lines, right? The problem with that is have like an Indo-Pacific Ocean, you retreat to the ocean. You have other factors that involve, drone warfare. We're learning Ukraine, and some background on that in the slide just a second. These drones make it difficult for combat casualty evacuation. Stay indigenous in the field for days at a time because of drone battery life and interests that you may have, and not just fallen soldiers, but the medical personnel going to retrieve them. So a lot is changing. And so next slide. I was, by the way, I was in Ukraine. I thought I was going to learn about, injury patterns and the damage control surgery course stuff for Ukrainian soldiers. And what I learned is there is a need to modify the concept of roll one, roll two, roll three, which are the destinations for combat casualty evacuation. Roll one, we can bring them to your stabilization tent. Roll two, move them to an operative theater somewhere to get them what they need. Roll three, more so they're. We have to change that because drones are fixed so you can't work with CNC. Next slide. So I'm not here to tell you there's an impending World War III. I'm not here to tell you. I don't want you to believe compliance. Exactly what I'm trying to my message. But we had a pandemic several years ago where we learned that places, regions, and systems where there was organized trade coordination, there was survival benefit. And we've done nothing as a system to national to really kind of crystallize that or grow from that. It's sort of almost forgotten. And now, yes, there may be a heightened threat, ways to multi-front war or combat. And then, yes, even with out of conflict, when it comes to the advances in drone technology as weapons, for example, Ukraine had not only at one point they had a very complicated submission spider web where they reached deep into Russian territory, destroyed more the Russian air fleet than has ever been destroyed in the history of the Russian Air Force. They did it on the Russian side of the skirmish line. So not only did they destroy these airplanes, they destroyed the notion you're safe side of your own side of the conflict. So make no mistake, terrorists are not on a life or where this capability. So the idea of mass casualty management as well as disaster preparedness is paramount. So out of all the reports, the two things that I personally took home is there may be opportunities to expand the military and civilian training partnerships, and then also the development of an arm which next slide. Liz, I don't think like Legos. Liz has a thing for emergency preparedness. She's got this niche and kind of disaster management. So this the National Trauma and Emergency Preparedness update, which is version 2, approved earlier in the year. I believe that in the old I'll feel the pressure. But Liz by the way is the vice chair for the CAT representing Georgia. At the COT level, and she's doing a lot with Hallmark right now. So I didn't want to say anything else about it because I'm not sure what she. It's a pretty important topic, and I hope we have some a lot of dialogue after this meeting. Next slide.
All right.
Is there any questions for me before Dr. Benjamin takes over? Please.
Gee, who's the RMOC coordinator in Georgia?
Liz Independent.
Where?
Liz is our representative from CAT.
Okay. But there's the RMOC coordinator I thought was DOD.
There is an NDMS, I'll tell you what's wrong, but there's an NDMS pilot project that's working in 7 areas of the US. I don't think we're in Georgia right now, yes. But there's parallel effort happening, and along with the issues on large-scale combat operations. I'll go give you more detail on that thing. Yeah.
Did I leave anything out, Dr. Cole?
No, you covered it really well. I think it's a great lead-in for the discussion tomorrow. I really hope you all can be here, and if not, I'm just happy to share the slides. I'm going to give an overview of kind of where the history of the unlock concept came from, what we learned during the pandemic and where we are now, and how it dovetails with the work we've been doing at the COT on the National Emergency Preparedness System. So really, the unlock is like at the center of that. So a lot of things are converging on the same concept, which means it's a good idea. It's a question of how we're going to actually make it work.
Liz, do we still have you?
Yeah, I'm sorry, I can hear almost everything, but every once in a while it drops out. Can you hear me okay, or?
Yes.
Okay. Yes, I mean, I think we are going to talk about it, like Dr. Bolger said, I think we're going to talk about this quite a bit tomorrow. I had only planned on doing a couple slides just to give like a intro to it, so people were kind of on the same page going into tomorrow. Would you like me to go ahead and do that, or I know it's getting a little bit late. It'll take probably 5-ish minutes.
Sure, I think, I'm up for it.
Okay, let me share, see if I can share slides. Potentially. See if that works. Does that work? Can you guys see that okay?
Yeah.
Yeah? Okay. So Dr. Bolger is going to talk about this a bunch tomorrow, and to what I believe was the question that I heard, there's a lot of different groups that are doing things to try to organize around RMOCs within our state. And so there's actually quite a few people involved in this. The GCC obviously was a centralized part of that, which doesn't exist anymore, but there's still a lot of different entities that are working on that, both in trauma, in emergency medicine, and EMS as well. So we can talk about that more tomorrow, but there's definitely a lot of participants. Let's see if I can, there we go. I wanted to start with, just to make sure everybody's literally on the same page, what is an RMOC? It's a Regional Medical Operations Coordinating Center. And that can mean a lot of different things depending on the state and what it's sort of designed to work on. But the basic core functions is that it is designed to sort of manage the transfer of patients across the whole hospital system, like multiple hospital systems, and sort of load balance and put the right patient in the right place at the right time. I know we talk about that a lot from an EMS standpoint, and the RMOC sort of concept takes that both from the EMS and from a hospital standpoint to try to load balance across our entire system. The basic functions are to have some sort of centralized access point that can be responsible for sharing information. And this doesn't supersede the individual hospital systems, information sharing and load balancing within the systems. It's really designed for when hospital systems are overloaded or need help outside of their system, a way that we can communicate across hospitals and or systems within our state and surrounding states in order to share information and help each other when we need to. And to this end, this has to be scalable. On a day-to-day basis, we often are completely self-sufficient and functioning, but we need to have a way to scale this need when and if we need it. And so the main purpose of this is to have some sort of situational awareness of what's going on in the different areas, figure out a way that we can load balance should we need to, in the same way as we did with COVID, which I think we did a great job with in this state, in terms of communication and load balancing. And then also figure out a way to integrate this response across both the hospital systems involving the national disaster medical system, the military health system, and really have a way that we can spider out that web of communication outside of our own sort of day-to-day. Dr. Bolger is going to talk about this a lot more tomorrow, but this sort of scalable concept, and I think what we need to think about as TMDs and within our group is sort of how this looks on a day-to-day. I think that there's a lot of things in terms of integrating into larger systems, but we need to think about what problems do we have on a day-to-day basis that this concept could help us with and be something functional day-to-day to help us load balance. So that way it can be muscle memory, something that we do all the time that then we can scale up should we need to. this idea of LISCO or large scale combat operation, which I'm sure Dr. Bulger will talk about more tomorrow, and I know Dr. Christie touched on already. But this idea that are we to have a large event, a worldwide event where we would have casualties coming into the United States, the military hospitals would be quickly overwhelmed, as would probably the hospitals that are involved in military civilian partnerships. So we need to figure out how to all partner together in order to accommodate this. And although this is sort of like a doomsday prediction, if you sort of really go down that path, you can really go pretty dark quickly. But you can think about this also for natural disasters or mass casualty events, and ways that we would work as a team within our state and surrounding states in order to communicate, load balance, and come together to share resources. So in terms of the COT, we're going to be, we're working on as a group sort of from all of the regions, so sort of all of the regions across the country. We're trying to work on a way to kind of deliver a toolkit to the region chiefs to implement RMOCs and establish, I guess, to help support already existent RMOCs, to help support RMOCs that are in process, and then help sort of ignite places that don't.
I have more for you.
Sorry.
Stop. Yeah. Can you get this to Tricane? I'm gonna just measure the.
Oh, there we go. But just to have a way to common language that we can use across the regions in order to talk about this and pitch it and figure out how we can integrate these. So we're going to be coming up with a roadmap, as well as a sort of a list of things that you can do to help first educate, and then who should be involved, how to start contacting some of the important key players, and then also have a slide deck from the COT so that we can really have common language and sort of all be saying the same thing. And this will hopefully integrate in with the advocacy groups and sort of across the pillars of the COT, so that we can really leverage the same conversation that's happening across the country from so many different groups. So more to come on this tomorrow, but I just wanted to do this just for a quick sort of 101. And if anybody has any questions, happy to answer.
Yeah, thanks, and thanks, Dr. Bulger, Dr. Christie, for that intro. That's exactly what I had in mind, just to kind of bring everybody up to speed on what we be talking about tomorrow, so it's not a brand new thought. So give it some thought over dinner, and come up with some really good questions, and we'll have a great discussion tomorrow. Anything else we want to discuss? I know we ran over a few minutes. Sorry about that, but I enjoyed I think we had a pretty productive discussion all the way around. And Liz?
Yeah, just something that came up in the GCTE meeting that I would like to extend to this group is that you guys could think about if there's any educational opportunities you potentially want to include in the budget for next year. Like, we used to do a statewide topic course or optimal course or TMD course. What are the educational needs that we could potentially help? Now's the time to really start thinking about that, because we start getting heavy into budget planning and preparation around January and February as the legislative session starts. So GCT is going to start thinking about that and put together what they think they want to do. And then if you guys, maybe the next meeting, you can entertain some topics on it, if that's even a priority. It might not be, but if there's something that you want, let's try to get a placeholder in for it early so we can make sure we can get it done.
Did we already go through the $1 million that we got, the educational grant through the foundation for training? Or is that a separate document?
That's separate through the State Office of Rural Health, aimed at just clinical education for rural Georgia.
Yeah, March calls.
I have a great update on that. Finally, Dr. Erica Mates from Augusta University They actually work, AU does an annual, big rural, trauma day, and, she actually did a great localized survey of the rural centers that they interact with, and got some feedback on items that they wanted to, you know, folks really wanted more educational. She presented it at our meeting in Callaway, and we actually contracted with her to push it out as like, because she's got the simulation, but we're paying for the simulation fellowship now. So I think right now there are 5 centers confirmed to do her rural simulation program, which will be essentially the March Pulse concept. We really just needed to put some real, like, you know, legs underneath of that. And
Well, I guess my question is do we need to put some money into that, or is there already some?
yeah, there's a lot of funding in that. So there's still about, I want to say somewhere, Dr. John, you remember getting so great in our head. It was like over $200,000 still in that. And so it'll fund her program for the first year. And then I'm sure that the commission will support another year of funding for that. So, because that would be great. That's bringing simulation right where it needs to be. Yeah. Yeah.
Cool, like time.
Well, I think we just needed we needed it to be in the hands of someone who could bring the simulation. That really accelerated. Thank you for asking that.
And that was something else, program that you can tell me a little bit more about that, I'm interested in that. I'll also tell you that the World Trauma Team Development Course is under revision right now, and so I think we'll be a new version of that course out within the next year. And that's another great way for trauma centers to do direct outreach to their own rural referring hospitals. In our state, we were able to get some money from the Traffic Safety Commission, the state, and to support RTGC specifically, again, worrying about rural traffic deaths. And that hospitals basically applied for a grant to host the course, and then the trauma center for that each city. So it's something to think about with educational funds, whether you want to develop some kind of program like that. If you already have money, or you could also talk to the Traffic Safety Commission, because we were able to get quite a bit of money from them in our state.
All right, anything else? Okay, well, I guess, we'll consider ourselves done for the evening. Feel free to grab and ask any questions or give some suggestions, and I appreciate everybody being here. Thanks to everybody who joined on as well.